us. Our next speaker is our President AIOS, Dr. Mahipal, who has definitely brought in vibrancy during the Corona times, a blessing for his tenure, for the different strokes of learning he has evolved for us. He is going to detail us on how to treat flap STRIAE. On to you, Dr. Mahipal.
Thank you very much, Dr. Chitra. I'll be talking about dealing with flap STRIAE, and the flap STRIAE can be classified in various ways, whether they are micro STRIAE, they are macro STRIAE, whether they are fixed folds or they are not fixed folds. So exactly when you are looking at STRIAE, they are wrinkles in the cornea which we see following LASIK. Quite often they are small and asymptomatic, and as Dr. Titial in his presentation talked about epithelial ingrowth, similarly when you are looking at STRIAE, what is very, very important is that is the patient symptomatic, and the STRIAE, are they large enough, and when they are approaching the visual axis, that is something which necessarily one needs to warrant a treatment. Now, the classification of STRIAE can be, as I told you, micro STRIAE, which are small superficial wrinkles, and these are usually asymptomatic, and these involve epithelium and basement membrane and the Bowman's membrane only. But if they run deeper into the stroma and they usually cause severe visual impairment, these are what are known as macro STRIAE. Now, what is the etiology of these STRIAE? So actually what happens is that there is a alignment problem between the flattened stromal bed. So normally if we are talking about a myopic or myopic ablation that has happened, so you are flattening the stromal bed, and what is there is that the posterior flap surface is there is a mismatch that happens, and there is a direct correlation with the quantum of tissue that you have removed during the ablation. That means that if you are having small ablation, the flattening would be less. If you are having larger ablation, the flattening would be more, and this mismatch would therefore be more. The second thing which is very important is that the thickness or the thinness of the flaps. These are so earlier when we started the laser vision correction, when folds were a problem at that time, ectasia had not come up. So like a Hansotome, when we started, it was 160 and 180 microns. And we wanted, even for my sister-in-laws, even I wanted that their flaps should be good. So actually I did a 180 flap. So that is that because we didn't want STRIAE, and we thought that the adhesion was much better with the thicker flaps. Now, microkeratome flaps are again, which are meniscus flaps, and they cause higher stromal bed irregularities. And when you are looking at the femto flaps, they are at 90 degrees, or you can actually have even an angle which could be more than 90 degrees. So the chances of having STRIAE are much less. Now, in case you have manipulated much more, and there is hydration of the flap, or there is dehydration of the flap, the adhesion and the stickiness of the flap will become different, and therefore the chances of having STRIAE are there. And also it is also important that if you don't iron or if you don't swab the flap into position and wait for it to dry, then these are going to be a problem, and therefore it is essential to observe the patient immediately after the surgery. Now you can see here, these are STRIAE which are involving the central part, and you can often see that the patient comes back with halo's glare, and the patient is always an unhappy patient. As Ram was talking about happy 2020 or happy patient, this will be an unhappy patient, and you have to dilate the pupil and try to look at retroillumination, and maybe an aberrometry can show you that there is a problem. Now, what is the management in case they are detected early? Actually, they should be detected on first day post-operative, even before going. If there are the STRIAE, you should send back the patient to the OR and have the thing redone. If it is detected early, you just can relift, hydrate the flap and replace and iron it. And this works only on day one if it is detected much earlier. Now, this is a case of a 35-year-old female, which I have shown earlier also. LASIK was done in 2019, June, developed flap folds. Patient went back, it was relifted and just put back, and the patient was not doing very well. So you can see in this particular case, I am showing you that there is a retroillumination, and you can see the huge amount of STRIAE which is there. Now, what is very, very important for managing these STRIAE is that the adhesion or the anchorage that you have of the epithelium into the folds has to be taken out. So just see, the moment the epithelium is taken out, you can see how macro STRIAE these are, how big these STRIAE are, and obviously this patient would be very, very unhappy. So the total epithelium needs to be removed in this particular case. You have to lift the flap, and you have to hydrate the flap. So you can see here that the flap is being lifted. As you lift the flap, you can see you have to, the undersurface of the flap also needs to see that it is clean. We are putting hypotonic saline. You can either put distilled water, and you can wait, you have to wait for the flap to actually hydrate. So once the flap has hydrated, that is the time that you have to actually go back and see this. You have to have two sponges which have to move and in the opposite direction. And in this particular case, you can see that we are taking at about 50 degrees of the spatula which we use for the ICC, and we are ironing the flap. So this is a technique that has been described because this loosens the folds that have happened. And this patient I am doing after about a year of the flaps being there in this particular patient. So you had to be very, very aggressive. So the aggressiveness is remove total epithelium, hydrate the cornea with hypoosmotic fluid or with distilled water, and use the back of a spatula at about 45 to 50 degree and try to iron it out. It's similar to a steam ironing of your clothes. If you have to have the clothes, the wrinkles and the creases done, you have to use a pressure there, and you have to have heat which is there. And this is the unaided visual acuity of this patient, who came to 7.5, and patient followed up for some time, and the patient is happy and didn't come back to me. I think the other important thing is that to sum up, I would say that you could also suture the flap which is there, and these sutures need to be placed perpendicular to the folds. And in some cases, PTK has also been described, which I haven't done myself personally. Now, epithelial ingrowth presents in about 1.7 to 5.6% of enhancement procedures. Some studies, only one study has reported a very high figure, but the moment you are relifting a particular flap, that is when you have to be extra careful that you don't do excess manipulation and you wait for a much longer time. And as was said rightly, that a bandage contact lens helps in these particular cases, which is there. And epithelial ingrowth has already been handled. So because once you are actually removing these flap stria, because you are relifting the flap, you are removing the epithelium, the chances of having an epithelial ingrowth post stria removals is much higher. And so you could actually look at removing any epithelial ingrowths, etc., or rest that are there. Fibrin glue can be used in these particular cases, which has been shown to reduce the incidence of flap stria. Very few instances of actually implanting the epithelium into the bed in cases of SMILE have been reported, but typically SMILE does not give rise to flap fiascos and such as the stria, micro or macro stria, or also the epithelial ingrowths which are there. So this is the important thing is diagnose flap stria at the earliest, dilate the pupil, do a retroillumination and do an aberrometry if required, and see how comfortable or uncomfortable the patient is. And you should intervene at the earliest possible if the patient is having discomfort and if the stria are coming into the visual axis. So that is what I would wish to say for management of flap.
Dr. Mahipal, one question. If you have a patient who has come to you after a bad road traffic accident with the flap quite crumpled, there are multiple issues there. Would you try to somehow salvage the flap or would you discard it?
So, Dr. Chitra, that's what was said. That has been the experience across the board, that at times, even if you sacrifice the flap, if it cannot, anything cannot be done, the refractive effect is very little. So it will totally depend on the situation the flap is as to whether it is salvageable or not. See, a road traffic accident normally, until of course the flap got amputated, is normally salvageable. Non-salvageable flats are if you have buttonholes, you have tears in the flaps, or you have infections, or you have melts. Those are the type of flaps which you may not be able to salvage, because an RTA, the patient had a good flap and the flap got dislodged because of not even an RTA or even a blow to the wrist thing or a football injury or whatever it is. So at that particular time, if the flap is there and you do not expect any infection, it is better to salvage. But in case you feel that already there is infection that is coming in, the flap is in a bad situation, then at times you may not be able to salvage it.
One other question. Supposing we know that for a macro striae, we are going to do epithelial debridement and then only deal with it. For a micro striae, it is not the second day, but the patient comes in much later with microstriae, would you want to do an epithelial debridement, or would you try to iron it out and do the other things?
No, the ironing, see, if the patient is coming back to you, they are not actually microstriae, because they are visually disturbing to the patient. That's why the patient is coming. So under those circumstances, if it is coming in the visual axis and if it is late, there is no way that until, of course, that is what I'm trying to say, be aggressive, because this is what was happened in this particular case. That this case went to a premier institution, the patient was picked up, the flap was relifted, they did they tried to do the stretching, etc., etc. No epithelium was removed, there wasn't any aggressive thing, the patient was back to square one. There are these anchorages which happen. See, there is a remodeling that has happened, and these anchorages of the stroma are very firm. So until, of course, you actually remove these anchorages, swell up the stroma so that then these undulations can go, they will not respond. So if it is a late management, it's only, I would say, the first 24 hours or maybe max 36, 48 hours that these stria, if they are there, they can be taken care by reposition. But if you come on to longer, 3, 5, 7 days or 1 week, etc., it is always better to remove rather than again having the patient to go back to the OR to remove these macrostria or stria which are there.
Dr. Praveen,
Many a time.
Dr.
Yeah,
Praveen?
many a time,
Yeah.
the microstriae are missed. So I just wanted to give my inputs. My macrostriae, the patient's visual acuity is reduced. So patient is unhappy and the vision also drops, and then you have to manage it. But many patients, the microstriae are missed, because central microstriae, especially when you have a thin flap, LASIK, and you're correcting high refractive errors, you get fine microstriae. And like Mahipal said, you have to dilate the patient and do a retroillumination examination. Otherwise, you cannot pick it up. It cannot be picked up on OCT also. But the best test for these are the OCAS or HD analyzer, which shows an increased scatter. So even though the patient is reading 6.5 or 6.6, they are very unhappy because they have a high degree of scatter. And this can be picked up in the HD analyzer, and rightly, the epithelium has to be removed for this, and it has to be treated aggressively. Otherwise, you will have an unhappy patient.
And what Shri is saying is absolutely right. There are patients that I have treated who have gone from one ophthalmologist to the second to the third and fourth, and they have said these are microstriae and nothing needs to be done. But the patient is very, to the extent that one patient I have recently treated was on antidepressants. The patient was so very depressed, and the doctors are saying there is nothing, we will not enter. There was a big dilemma. So I said, no, please come, I will treat them. And then there was a big debate because the patient was a very anxious, depressed patient. So under those circumstances, the patient had a lot of discussions. I said, no, please let us not ignore these, because you are very, very symptomatic, and you have gone into a situation where you have left your job also because of these microstriae, and they were right in the center.
Yeah, if you do HD analyzer, you can typically see the OSI is very bad. Though the patient has 6.6 vision, the OSI will be 5 or 6, which shows that the quality of vision is very poor. That's why they are depressed.
Dr. Praveen, any other question you have?
Nothing from the panel, but then for all the attendees, would request them to put in your questions on the Q&A panel so that we can pick up your questions for the panelists as well. I think also, Dr. Mahipal, do you ever use PTK after you derided the epithelium if you have flap stria that don't go away?
See, that's what I said. I have never had the need to do that, but obviously that is written, and I gave the disclaimer that for sake of completion, I told. But yes, in case there are, and that is when the rugosity is not going, the irregularity in the cornea is not doing. So you can go ahead and do a PTK. It makes good logical sense to do that. In case they are recalcitrant to you're trying to smoothen them out using all the techniques that I have said. But I have never had a problem in case I have been aggressive enough to treat these stria and do them the way I normally do them.
Just an observation. I mean, the post-smile, as Mahipal mentioned, the striae do not occur. But I have found some wrinkles, especially if you have removed a high-power lenticule. And this is more because of wrinkling at the Bowman's level. So routinely nowadays, after removing the lenticule, I hydrate and then do a certain amount of ironing from up down, about 8 to 10 times. I do find that this gives a more pristine cornea and better visual acuity on post-operative day 1.
Dr. Praveen, shall we go on to our next speaker? Thanks a lot, Dr. Mahipal.
Yeah.